I'd like to invite Dr. Ušinskienė from National Cancer Institute to present us the situation of radiology equipment for treatment, for diagnostics. How do we diagnose prostate cancer? How we try to treat it? Hello, Jurgita.
Hello, dear colleagues. To be invited to this international conference. And I am a chief of diagnostic and interventional radiology department, and my presentation will be, I will speak about introduce the department and its possibilities. I will give short overview of the main procedures that we are doing in our department and a few examples of the clinical cases. So diagnostic and interventional radiology department, we have two X-ray equipment machines, two portable and two stationary machines, one MRI 1.5 Tesla equipment, two CT computer tomography equipment. One is mostly dedicated for interventional procedures. We have also ultrasound biojet fusion biopsy system. We have one ultrasound histoscanning system. And recently we have got MRI-guided prostate biopsy, a robotic system from Soteria. Here in the pictures you see our team. So main team for interventional procedures is Dr. Mantas Trakimas and his team radiation technologists, nurses. Also in the lower picture you see an example of robotic biopsy system. I am very proud of my department because we have all four radiologists dedicated to prostate cancer diagnosis and interventional procedures, and two of our radiologists have got a certificate from Radboud University, and they have successfully completed MRI prostate detection of the prostate cancer at Radboud University Center. Also, we are a part of EBU host center, and we do all imaging what concerns prostate cancer diagnosis. If to speak about our department statistics, so in 2021 we had over 8,000 patients coming to our department, and mainly we scanned our patient with MRI over 3,000, with computer tomography over 9,000, with X-ray and ultrasound systems. If to speak about prostate, so MP MRI in whole, it's about 24% of total MRI in 2021, and also there was over 40 cases of the whole body MRI dedicated for systemic prostate cancer, lymph nodes and bone mets. Our prostate biopsy data, we see that in total number prostate biopsies has decreased, of course, because of a pandemic. But MRI-targeted biopsy is increasing if comparing with the 3 year period. And you see that it's gaining popularity between neurologists and radiologists. Computer tomography for prostate cancer imaging is about 6%. We have a third phase clinical trials with metastatic castrate-resistant prostate cancer and non-metastatic castrate-resistant prostate cancer. Our radiologist participates in more than 23 clinical trials, and you see computer tomography in 6% works only for prostate cancer. Our interventional procedure leader is Mantas Tarakimas, and also tumor ablation procedures has increased despite of pandemic situation in 2021. We have done more than 10% if compared with previous year. And here in our center, carrier ablation, microwave ablation, radiofrequency ablation of the various kind of tumors. Most is liver metastasis, kidney, lung, bone, and thoracic, some kind of breast metastatic tumors are treated in our center. In total, if we see inpatients, for the inpatients it is not funded, so it's the hospital who pays for these investigations and imagings. So 15% of oncology patients is done in our department. Usually it is emergency cases, some complications. So, of course, abdominal surgery department is the first in this place, and thoracic surgery and urology department is 15% of those emergency patients. We have analyzed our multiple parametric MRI results, and here we have classified what were the findings of the multiparametric MRI. Our data showed that, and we may have this conclusion, that we do not perform unnecessary multiparametric MRI. As you see, clinical significant prostate cancer, PIRATS 4 and 5, was majority of all those cases, and it was about more than 90% of these cases. Analysis of our data, PIRATE score, or correlation with Gleason score, we see in this analysis that no clinically significant cancer was missed. There were a few false negative MRI evaluated as PIRATE 2 for Gleason 3+3, but clinically significant cancer was mainly found in PIRATES 3, 4, and 5th grade. I am also glad to introduce you that National Cancer Institute and doctors of our department participate in artificial intelligence project with a budget over 12 million. ProCancer Eye vision is to deliver a ProCancer Eye platform featuring a unique collection of prostate cancer multiparametric MRI images worldwide in terms of data quantity, quality, and diversity. To focus on delivering novel artificial intelligence clinical tool based on 3-stage ensemble modeling. And for advancing characterization of prostate cancer lesions, assessment of the metastatic potential, and early detection of the disease recurrences. AI is transforming the field of medical imaging and has a potential to bring medicines from the era of sick care to the era of healthcare and prevention. So we are a part of this international project. There are over 20 countries participating in this Horizon 2 project. Because of the COVID pandemics, speaking or about the prostate cancer screening, we are also do multiparametric MRI for some cases. And we see the number of the screen PSA man dynamics in Vilnius region. Vilnius Territorial Health Insurance found data in 2020. We see that the screening has decreased due to the pandemic situation. So in Lithuania, it is most worst for the prostate cancer screening. Of course, all screening programs has decreased, but worst situation is for prostate. And patient information about prostate cancer prevention and number is decreased over 44%. In a National Cancer Institute, majority of the screening programs in our department, we do prevention mammography, and also it has decreased in 2020, but increasing in 2021. But prostate cancer screening program is a little bit declining over during these pandemic years. If we see the screening results, what cases we found from the screening program, a total number of 90 cases were done last year, and adenocarcinoma was diagnosed for more than 50% of all screening biopsies. We also have possibility, and now we use already 3 years for electronic history reports, and we also use structurized MP MRI reports where we radiologists can on the pictures they can describe where exactly is the lesion, and it helps, of course, to communicate with urologists more clearly in anatomical field. For the one of our imaging, we do whole body diffusion and T2, T1 sequence MRI. So here we see a case that has lymph nodes in aortic region, aortocaval region. And in these cases, scintigraphy may not help for you. So in these cases, we do whole body MRI. We can do it from head to knees. So it's long, and it takes about 45 minutes for the patient to lie down, but you can evaluate soft tissue, lymph nodes, and bones. We have whole body MRI indications, so it was in the literature, but Hani in 2017, so for the bone and lymph nodes assessment, for biochemical recurrence after primary therapy, for M0 castrate-resistant prostate cancer to detect the onset of metastatic disease, and also for bone, lymph nodes, and visceral assessment for known metastatic disease, for the serial tumor response assessment. Also, it's possible to do brain MRI for the small cell known neuroendocrine tumors. Some of the cases can be followed up with whole body MRI. So for example, 8-9 weeks for 6 months for treatment with unknown optimal timing, every 12 weeks later, and for clinically approved treatments, 16 weeks for M0 castrate-resistant prostate cancer, or yearly in case of clinical changes. We also try to use metastasis reportant data system for the prostate cancer. It is written in the literature, but the Hani MetRat system, so it is a standard most for the clinical trials, response criteria for the bone, soft tissue, and local disease, regional response, highly likely responding, highly likely progressing, or overall response as RECIST 1.1. So little is known regarding the accuracy of the whole body or axial MRI patients with biochemical castrate-resistant after radical prostatectomy or radiation therapy cases. Therefore, the role of this technique in detecting occult bone or lymph node metastasis in the case of biochemical resistant prostate cancer remains to be assessed. But here we have a case after radical prostatectomy, and you see follow-up after 3 years. PSA is increasing from 0.6 to 6, and at the moment when we did a whole body MRI, you clearly can see metastasis, which looks hypointense, so black in the bone marrow. You see osteosclerotic black metastasis, hypointense in the whole spine. Also, some increased lymph nodes. So it's quite a good tool that is used in our clinic. So I would like also to have a few minutes for your attention for the few cases. So 60 years old male, he was diagnosed in 19 prostate adenocarcinoma, Gleason 4. Prostatectomy and pelvic lymphadenectomy was performed, and radiation therapy with 70 grays. You see he was followed up with a PSA dynamic, and you see the curve how the PSA increased. And at the time when PSA level was 5, the bone scan and whole body MRI was done for this patient. So with the whole body MRI, you see osteosclerotic metastasis in the spine. Please remember that those who are not radiologists, if you see in T1, in T2, or in fat suppressed sequences black, so black lesion in the bone, so you must think about some malignant lesion in the bone. Hormonotherapy was performed for this patient, and yes, he is still in a good position now. So second case, also prepared from one of our doctors. So man, 69 years old, in 2011 he had prostate adenocarcinoma, Gleason 7, treated with radiation therapy, hormonotherapy. Also in 2016 he was diagnosed with the second tumor. It was a pancreas tumor, the head of the pancreas tumor, and he was operated and treated with chemotherapy. He was also followed up for these two tumors. Usually he was followed up with the CT and MRI and scintigraphy as well, because scintigraphy is a standard procedure to detect bone metastasis. And you see that PSA levels was increased. And when we performed at the when PSA level was increased, we performed a computer tomography and found a round oval lesion, about 11 millimeters, with contrast enhancing signs. So, of course, when radiologists see this round oval lesion and patient has even two tumors, I think all radiologists and immunologists could think that this can be metastatic disease, progressive disease. But in this patient, uniportal wart segmentectomy was done, and pathological diagnosis was found: invasion of round worms into the lung tissue. So not all that is oval, not all lesions that is solitary oval lesion, not all these lesions are metastatic. You always need to confirm it with histology. Another case of the whole body MRI, you see the lesion was found in the skull base, in the bone scintigraphy also was performed for this patient, and you see that this patient has metastatic disease in the occipital bone. Of course, bone scintigraphy is a standard procedure, but whole body MRI also can more clearly see soft tissues, what is around, and lymph nodes. and visceral organs. So biopsy from this bone lesion was metastasis of the prostate adenocarcinoma, and oligometastatic disease was diagnosed, and radiation therapy was performed, and we still follow up this patient. So why we do imaging for oligometastatic disease? Because for focal and metastasis-directed therapies, because you do not need to treat whole body, you can do focal. And how we can do it? In our clinic, we do not have PSMA PET-CT, we do not have whole line, so we perform whole body MRI, and as you saw from the third case, it is quite good accuracy of the whole body MRI. What I would like to ask for urologists and for the doctors oncologists who send for the imaging, that clinical information, feedback, histology, what was found is needed for radiologists. Why we need this information? Because, for example, short PSA doubling time is strongly associated with high likelihood metastasis development and progression. Steroid and abiraterone therapy also alters bone marrow fat composition and can affect image appearance. Without knowing this all information, we can make mistakes. So that's why communication team is very important. And one picture of our social meeting every year for the prostate cancer. We ran a small marathon, and radiologists from our department participate in this event as well. So thank you for your attention. Do you have any questions? Mantas, do you see if there is any questions or any comments?
Actually, I don't see any questions, but I have a question for you. Every year we have some new updates, new things in our department. How do you think next year? What novelties we will have in our department for prostate cancer, or maybe just for any cancer treatment and diagnostics? How do you think about that?
So I hope that we will start clinically to do more and more to use this robotic system that we have. So MRI directly taken prostate biopsies. Another, what we are planning, so we plan to acquire a new angiography system with a fusion technique for the computer tomography and magnetic resonance imaging. I think it could help you, Mantas, to make of course, it's not direct method to diagnose prostate cancer, but mainly for the complications.
Yeah, but I think it will be possible to do some focal therapies with these new techniques.
And also focal therapy, okay, focal therapy. I think that urologists has and our department has this cryoablation system. We do cryoablation for all our body tumors, and probably we will make more for cryoablation for the prostate cancer tumors. Sure, we must start with the clinical trials and later go to the clinics.
Okay, so thank you very much.